My name is Tomokazu Nagasa. I'm a RCIS, to the Registered Invasive Cardiovascular Technologist. And Dr. Cevik want to talk in this session today, but he's on call today, so he unfortunately couldn't come here. And he just said that substitute me and do it. So I do it right now. And background is 64 years male, and CABG in 2001, and CAD and non-STEMI in 2015. And we found for the occluded SVG for the circumflex and SVG for the right coronary, and patent to the lima to the LAD. And chronic systolic heart failure with the ejection fractions of 35 to the 40%. SVG to the right coronary artery graft with a 2.2 centimeter aneurysm in 2015. And ICD in place, and hyperlipidemia and hypertension and emphysema. And also the patient has a current tobacco abuse, and carotid stent bilateral moderate, and PVD, and stent to the bilateral to the iliac artery, and stent to the AAA. And patient undergoing to the severance to the CT for AAA and TAA. And aneurysm SVG measuring to the 5.4 by 5.2 centimeter, following by the CABG in 2001. And these small ones are contrast we can see inside. And so we refer to the cardiac surgeon, and we found for the inappropriate surgical candidate due to the prior stenotomy and going to the tobacco abuse, emphysema, and low ejection fraction, and patent to the lima. And her team decided to proceed with the transcatheter exposed to the SVG aneurysm. So that angiogram LAO showing for the all aneurysm in the shape. So we did a proceed, 8 French right femoral artery access, and 8 French multi-purpose guide catheter with 8 French guide liner, and balloon assist tracking of the guide liner technique, and Amplatz is 10 millimeter. And that was a LAO cranial, and it's a little bit different view. And first, we don't want any rupture, and so we're using the same PCI technique, and using the BMW wire, and 3.0 times 15 balloon, and we're using the balloon assist tracking of the guide liner technique. So it's a balloon to the deflate, and a little bit to the pressure for the section, and guide liner going on to the easier. And again, we don't want anything for the to the rupture. And now the guide liners go through to the SVG, the osteo. And after that, advance for the Amplatz vascular plug and 10 millimeter. And that was the same technique for the PFO, and first disc for the open, and we pull back for the whole system with guide liner. And after that, pull back to the guide liner, and second and third disc to the open. And that was a final check for the before the deploy. And after the deploy, we check for the pigtail. And now the contrast spot is gone, and all disappear, and now the close it. And now the conclusion, and SVG aneurysm are the uncommon complication of the CABG with rupture, confirmed high mortality. And percutaneous treatment of the SVG aneurysm is possible with a vascular plug. Thank you very much.
Great, thank you. Any comments from the panel?
Yeah, a great case. It illustrates one of the most simple cases you can do. I've done one of these on a 13 centimeter saphenous vein graft aneurysm. And invariably, the surgeon always says it's not a surgical candidate. Why? Because that vein graft aneurysm is right against the sternotomy. So they say that you cut into the sternotomy again, first it's scarred up, but secondly, that aneurysm is right there and it's going to rupture right on them. So invariably, they say not a surgical candidate. in our case, we use this vascular plug as well, the vascular plug 2, and you just have to consider that you can't coil this because, of course, all the coils will just fall in the aneurysm. You'll use too many. One question I had is that there was flow going down. Did you explore whether there was any flow distally? Was the vein graft still functional in some way? Because in some cases, people have actually used covered stents to reconstruct the vessel the entire way. Was that explored at all?
That was the SVG is already closed, so he didn't think about any that kind. So also he think about the coil and too expensive, and glue, and maybe in the aorta and too dangerous, and like a SVG occluder, and we have some osteo lesion, so we have a distance. So that one's work. He think about the more as deeply, but finally, he decision for that plugs.
Yeah, that's definitely the most cost-effective way. It's also a unique procedure where you don't use any heparin, where you actually want it to clot off. It's kind of feels very satisfying and simple.
Yeah, it's a good point. Sometimes the imaging is difficult because of the abnormal flow there. So using the guide extension further down into the graft would be helpful there. But I'm not sure if that was done ahead of time or seen on CT. So.
Great, thank you so much.